My title of my topic is Intervening on Chronic Respiratory Disease, a Global Health Perspective. A little bit about me, as Dr. Welton shared, is I'm a pulmonary and critical care doctor, but have spent a lot of my career working in chronic diseases, particularly lung disease. And so this talk today is going to focus a little bit more on some of the research programs that we are currently involved in between MedStar Health and Georgetown University in our collaborations globally. I don't have any disclosures. So our focus today is on understanding how does lung function, what is lung function over the lifespan? And then how is lung function impacted in different parts of the world, as it is not the same as in the United States or other developed countries. And then to appreciate the trials that we are currently working on here at MedStar Georgetown for chronic respiratory diseases. So overall, 454 million people globally live with a chronic respiratory disease. CRD is chronic respiratory disease. Responsible for 4 million deaths and 33.5 million disability-adjusted life years. Just briefly, a disability-adjusted life year is when you live in a state of not 100% health. So just to kind of think about that when I use some of these terms, that it's a state of disability. And it's the third leading cause of death and disability worldwide. Some of the common chronic respiratory diseases we see globally: chronic obstructive pulmonary disease. I'm sure you guys see this on almost every H&P you write as an intern. Asthma, chronic bronchitis, and preserved ratio but impaired spirometry, which is something that is coming out of the woodwork, in which patients don't quite have, let's just describe it as they don't quite meet the definition of COPD by spirometry, but they do have impairment in lung function, and that is something we are working on. There's currently a lot of research going on in this area. So how do we measure lung function? So if you were to come and see Dr. Jameson here in clinic, and he wants to measure your lung function, he would send you over to the PFT lab to have spirometry and probably some other advanced testing. But since we're talking about global lung health, we're just going to talk about spirometry today, because there's not really a good way to measure other types of things such as diffusing capacity and lung volumes when you are not into an isolated lab in a large hospital such as this, or even some of our smaller community hospitals have spirometry, have lung function testing. So today when I talk about spirometry, we're talking about spirometry that can be conducted in the field or technically can be conducted at the bedside. The measurements that we look at are your FEV1, which is the forced expiratory volume at 1 second, your forced vital capacity, your FVC, which is the total amount of exhaled air, and your FEV1 to FVC ratio. So when we talk about COPD, typically you have an FEV1 to FVC ratio of less than 70. There are a number of different definitions, but that's been kind of the generalized overall approach. And then you have an FEV1 that is less than 80%. When you're talking about PRISM, which I described earlier, your FEV1 FVC ratio is not lower than 70%, but you do have an FEV1 less than 80%. What I'm showing here in this picture is one of our patients in a large COPD trial in Peru getting spirometry in his basement. This was taken with his permission with a small spirometer. It costs about $40. Our team, when we do studies, we typically have probably about 100 of these spirometers that we use in the field. We're also going to talk about children today. So children have lung function measured very differently. We use a technique called oscillometry, which captures the natural airflow during quiet breathing. So if you use spirometry, you have to blow really hard and into a spirometer. In an oscillometer, you just breathe passively. The challenge with oscillometry is that the equipment's very expensive. So an oscillometer in the field, as I told you, a spirometer is $40, an oscillometer is $15,000. So for a large scale study, we might own 2 or 3 of these because they're expensive and they break constantly. They're also difficult to use because their lack of standardized protocols. I can say that analyzing data with oscillometers is very challenging and it becomes more skilled. In certain parts of the world, oscillometry has never been used, and that's something I'm going to talk about later. So lung function over the lifespan. So is everybody born with their highest level of lung function? And the answer is no. Your lungs grow over a period of years. Um, it's been generally accepted that lungs grow to about 25 years of age. Although I just saw an article this morning that was published in the Lancet Respiratory journal that showed women's lungs peak at age 20 and thought that maybe it's a little bit earlier than 25, which is interesting. So there probably are definitely some male and female differences here. But not everyone's lungs will grow and develop the same. They're impacted by different types of influences, such as during fetal development, smoking during pregnancy, secondhand smoke, air pollution, lack of physical activity during pregnancy. This isn't just something that occurs once a baby is born. This all occurs from conception on. Then you look into childhood and adolescence. Are children exposed to these different pathogens? Are they going to reach their maximal lung function? And then you have adult loss once you reach the age of 25 to 30 and lung function plateaus. And these are due to some of the same influences from tobacco, air pollution, allergens. So what is normal lung function decline? So once you reach your plateau at age 25 to 30, which is bad news for everyone here in this room probably, is that your lung function is declining. And some of the largest cohort study shows that it declines, that your FEV1 declines at about 17.7 to 46.4 milliliters per year. So on median 22, we say, you'll hear us talk about in the pulmonary world, 20 to 25 milliliters a year. Men do have a faster rate of decline, but that's because their lungs are larger than women's. So when you look at it, though, overall, they decline at the same rate that women do. But there are things that contribute to expedited lung function: environmental exposures, air pollution, allergens, tobacco use, lack of physical activity, and pulmonary infections. So let's talk about each one of these. Tobacco use. So it's the leading cause of preventable disease in the world, more than HIV, tuberculosis, and malaria combined. Smoking has become an epidemic in our developing countries. And one of the reasons that's occurring is because as these countries develop more wealth than they did years ago, smoking is considered a sign of privilege, and people are doing it more readily. So in low and middle income countries encompasses about 82% of the world's smokers and 74% of the total consumed tobacco products. So tobacco has now been associated in the 2019 Global Burden of Disease study with half of the avoidable deaths worldwide. Respiratory infection, something we treat very commonly around here, especially in internal medicine. There are 489 million cases of lower respiratory infections each year that are responsible for 2.3 million deaths. All this data I'm giving is based on the Global Burden of Disease study, which is the large study. It's done about every 10 years. There's a team at the University of Washington that's responsible for this. The last one was done in 2019. We should be expecting another one in the next couple of years. I'm on this graphic here. What we can show is this came from the Lancet Respiratory journal of a cohort of patients who had COVID. And what you can see here is in red are the patients who had very severe disease, and in green are the patients that had less severe COVID. If you look in the first box on your right, you see the infection where their lung function drops. They get some recovery, but noticeably the patients who had severe COVID always remained lower than those in lung function that didn't. So this is a very good example across multiple diseases. It's been studied a little bit more extensively now in COVID since the wave, but a few years ago in the number of deaths. But this fits the picture of most respiratory diseases, particular infections, particularly viral. Lack of physical activity is another issue, attributed with 830,000 premature deaths and 16 million DALYs lost annually. We're going to talk a little bit about a project in Nepal, and this is one of the new physical activity centers that has just been installed in Bhaktapur city. As physical activity hasn't really been an important part of low and middle income countries, and there's a lot of reasons for that. So first of all, when your focus is on surviving and you don't have a lot of resources, physical activity isn't the first thing you're thinking of. The second thing is safety. So it's not like here in Georgetown where we can go out for a run safely and not think twice. People are having to think twice. They might get attacked. The roads are rough. So physical activity just isn't as abundant as it is in developed countries. So there are some perspectives on that. Air pollution. So here is one of the things we're going to really focus on today. Air pollution is a big attribute and something that we're very concerned about. And so let's kind of break it down a little bit more here. So we have outdoor air pollution, which is your ambient air pollution. Then you have indoor air pollution. So just because you're inside doesn't mean your air is clean. And that's something to think about, particularly when you're thinking about your patients and what could be going wrong. In developed countries, we start to think about construction materials. Are they exposed to formaldehyde, mold, allergens, cigarette smoke, or cooking on a gas stove? That has become a very big topic here as gas stoves are not clean necessarily that many of us have in our homes here in the DC area. Underdeveloped countries, we largely speak about the burning of biomass fuels, particularly in our rural areas. My work has primarily been in household air pollution in low and middle income countries. So I'm going to kind of focus on that for a minute. I call it Adventures in Household Air Pollution because it has been part of my life for the past 15 years. On the right upper corner, when I first learned more about this when I was hiking to Mount Everest between medical school and residency, and every home when we trekked had burnt biomass fuel for cooking or for heating. On the bottom corner was when I went to a home of one of the porters who helped us with our hike, and his wife cooked, and the whole room was just filled with smoke. In the middle is a picture of my dad standing in Slovakia outside a home where his family's from, where they burn biomass, and this was in 2018. With the picture below, that's all biomass being burnt. And on the right is in Puno, Peru, one of the places our team works. Just for some perspective, over a third of the world still uses biomass fuels for cooking and heating. And about 49% then when you look at the world as a whole, 49% of the world who lives in a rural area burns biomass fuel for cooking and heating, and 14% of the world that lives in an urban area still does. There is an energy ladder. So when we're talking about low and middle income countries, there is perspective that they just can't afford expensive fuels like we have here in the United States. So when you're looking at very low income countries, you're talking about crop waste and dung. Then you move up the ladder and start thinking about charcoal and coal. Coal's often in the news these days as not being a clean fuel. Then when you get into middle and high income countries, we start thinking about other things such as gas and now electricity. Now the big talk of EV cars, electric stoves. This just isn't part of low and middle income countries. So what does biomass fuel collection look like? So the picture on the left is in India. of women collecting fuel for cooking. On the right is a picture in Puno, Peru, where those are dung patties that have been prepared, collected in the field. They're dried on a wall, and then they're burnt for fuel. These are a few more pictures of Peru and the different processes where they are putting together these patties for burning. And this picture is a woman in Puno, one of our study participants, who is currently cooking over her biomass stove. Can you see her very well? And the answer is no, because it is smoky in there. This is what her stove looks like. It's covered in charcoal and ash and soot. And this is the ceiling on the roof with all the soot hanging down. And the family's breathing this every day. So what type of pollutants are released? We're talking about fine particulate matter 2.5. So those are particles that are less than 2.5 microns in diameter. We're going to look and see how this impacts lungs. Nitrous oxide. These are released often by our gas stoves in our homes in DC, just for food for thought. Carbon monoxide. We have carbon monoxide detectors in our homes and in our hospitals, but this is not prevalent in our low and middle income countries, and black carbon. So to put it in perspective, a particle of particulate matter 2.5 is smaller than a piece of human hair. So it gets inhaled, it gets deposited in the lungs, it inflames, and then you get some soluble components that then get into the bloodstream and cause oxidative stress and inflammation, leading to disease across the spectrum of the body. A little bit more perspective on size-wise. So if you look at the picture on your left, you have 2.5 particles. Those are the orange ones. Those get into the upper bronchi. When they get even smaller down to 0.1, which some of this particulate matter does, it really deposits in our lower lungs. Larger particles primarily stay in the upper airways. So size does matter. Ambient air pollution tends to be a little bit of larger particles in general. So just a little bit about how this impacts your health. In pregnancy, it's theorized to be due to chronic hypoxia of the fetus, and which has been evaluated in mouse models. Nobody is going to trial this to see expose women and see if that directly expose women and measure. But when your body does not get enough oxygen when you're pregnant, your fetus does not get enough oxygen, then you get growth restriction, low birth weight, and preterm birth, which are associated with long-term adverse outcomes and development of long-term disease. Cardiovascular, 13% higher risk of cardiovascular disease and 21% higher risk of cardiovascular mortality. So some of the things that occur are increased risk of stroke, accidents, and cardiovascular accidents, heart failure, and hypertension. Interestingly, though, there's been no association with myocardial infarction and preeclampsia and carotid intima media thickness. So the thickness of your carotid artery, which has been associated with increased risk of stroke. So that has not shown to be a big marker. Neurologically, animal models have shown neurodegenerative disease, and small observational studies show decreased cognition in children, delays in development, along with increases incidences of depression. Respiratory, now my part. So our Dina Goodman, who is at Harvard, and I did a systematic review and meta-analysis on this topic. And we went through different diseases. So the data is not very clear, but there is likely a high association with pneumoconices, but multiple cases, but not any definitive data. There is association with head and neck cancer, lung cancer, pneumonia in children, and COPD. And TB. Interestingly, though, asthma is not associated with household air pollution. It is highly associated, though, with ambient air pollution. One of the models that we could theorize based on different exposure response curves is that if you are continued to be, you are exposed from birth, you will see that you never reach your maximal lung function, and then you continue to decline as you more rapidly than someone who was not exposed. So intervening upon this at any point could help prevent this decline, as what large scale exposure studies have shown. One of the things I think is really interesting about household air pollution is it tends to be a little bit more inflammatory as opposed to tobacco. When you look at a bronchoscopic differences, on the left, you see biomass exposure, where you see some carbon deposits, you see an inflamed lung. And on the right, it's inflamed, but they have a different picture. And so there is a different phenotype with biomass COPD compared to tobacco-induced COPD. You tend to see, with biomass exposure on lungs, you tend to see reduced small vessel areas and more airway remodeling. So when you see your patients coming in with really distorted airways and they have been exposed in different areas of the world where they may have grown up, that is something to think about, that they may have been exposed to different household air pollutants. But it also has a little bit different picture with lung function doesn't decline as quickly as with tobacco smoke. And more lower lung emphysema compared to upper airway emphysema. And like I said, is more consistent with small airway disease. This is a picture of a patient with biomass-induced COPD. You'll see some more bronchiectasis on this picture and more airway remodeling compared to a typical COPD developed from emphysema. So like I said, consider as a clinician here, just think about it. When you see a patient coming in with severe lung disease and distorted airways, were they exposed to biomass at some point? Are these some of the things you need to consider? Should you be thinking about treating them slightly different? They may respond differently. It tends to be more inflammatory, so should be targeting more of an inflammatory picture for these patients. So now I want to kind of talk a little bit about what are we doing to try and prevent the development of biomass-induced lung disease. So we, with the sponsorship of the NIH, the former administration's NIHs, we had done a liquefied petroleum gas stove and fuel distribution intervention in Puno, Peru. And what we did was we enrolled 180 women in Puno. Women are the primary cooks who use biomass stoves. 90 received the LPG stoves and direct fuel distribution for 1 year. And the other 90 cooked with their biomass stove. And then, to be equitable, we provided them with the LPG stove and fuel distribution the following year. I spoke a little bit about Puno, but Puno, Peru, it is on Lake Titicaca down in Peru. It's on the Bolivian border. This is a picture of me from probably 6 years ago while we were traveling from the airport to Puno. And you can't see it clearly, but my oxygen saturation is 85% as it is at 13,000 feet. So one of the things I put this up here to tell you that if your patient is transiently hypoxic to 85%, it is okay. I was perfectly fine. It'll be okay for a couple minutes. Don't do it long term, but you will be okay for a couple minutes, okay? We actually looked at everybody in the van and nobody had a oxygen saturation greater than 88%. So this is the Puno region, south of Lima. It's a very rural area, as you saw in those pictures earlier. rural, isolated. In our study area, we travel typically, our whole boundary is about a 4-hour drive around all of our communities. So it's quite a big area that we cover. So as our results in the household air pollution trial, these are box plots. And what you can see on the top right-hand corner with our orange is the control and blue is the intervention. Our particulate matter levels fell dramatically in our intervention groups. Below, we have our carbon dioxide groups. You can see a decrease. You can also see in black carbon on the right upper corner, and the same with NO2. So we had a remarkable reduction in exposures. We didn't have any differences in pulmonary function. This is the peak expiratory flows, and we did not see any statistically significant difference between our two groups. This is over a period of 1 year. So we also didn't see any differences in blood pressure, and we marked that by a degree of 10 millimeters reduction. Nothing in the St. George's Respiratory Questionnaire, which is a very sensitive questionnaire used for research in patients with COPD and idiopathic pulmonary fibrosis. We didn't have a change in quality of life. And then standard metric quality of life surveys, the SF-36 and the EQ-5D, we didn't see anything. But we didn't stop there. We went on to a larger scale trial called the Household Air Pollution Intervention Network Trial, HAPPEN. It was an 18-month randomized controlled field trial, which distributed LPG stoves and fuel distribution to 3,200 households. We enrolled 3,200 pregnant women in Guatemala, India, Peru, and Rwanda. So there were 800 women enrolled at each site, along with 200, we called them older adult women. And let me define that because I found it a little struggling for myself, as it's defined as a woman over 35. So yeah. And then an index child is the child that was born to the woman. So these women all used biomass for cooking. We had 4 primary outcomes. If you used an LPG stove, did you not have as many low birth weight babies? Was there a lower incidence of severe pneumonia over the first year of life of the child? Was there less stunting of the child and a reduced blood pressure in the older adult woman? And that's a woman over 35. As this is a pulmonary talk, we're going to talk about pediatric pneumonia specifically, and this is the area I worked very heavily in. Just from some perspective, pneumonia is the leading killer of children in the world, of children less than 5 years of age. It's particularly very high mortality in children less than 6 months of age. And this is despite we've increased vaccination coverage, nutrition, and the integrated management of childhood illness algorithm, which is an algorithm set out by the WHO. It's very sensitive, so pretty much any child that comes into a clinic will likely get treated for pneumonia with any respiratory symptom. The goal is not to miss a child. It's a different perspective than we take here in the United States. Annually responsible for 700,000 to 900,000 childhood deaths and 13 to 16% of the deaths in children under 5. But determining the incidence of pneumonia. So we have these 800 children born at each site. How do we determine how do we decide what makes them a case of pneumonia, number one, and how do we screen them and find them over the course of this year? This was very tricky. Believe it or not, the definition of pneumonia is not clear. What we think about as a definition of pneumonia here in the hospital does not work for a research purpose, because you're going to have if we asked everyone here in this room, everyone's going to have a different definition and may call a case differently. And it's not to say you're wrong. It's that there's no clear definition. But if you're going to do a research study, you have to have a clear definition. To put it in perspective of what this means, there was a large panel convened years ago, about 10 years ago now, with 200 x-rays of children, and they took pediatric pulmonologists and had them all interpret it. There's about 50% agreement on what defines an opacification. And this is pretty common in general across radiology studies. So it's challenging to do these types of things. So we convened a global panel of experts and had 4 meetings that were held to determine this definition, and it took 4 years to create, which is quite painful to think about. Mm, mm. And what we decided to use as our definition is we screen for respiratory signs. So children less than 12 months of age with cough or difficulty breathing. Then how severe was it? Our goal here was to capture severe pneumonias that would likely kill children. And so we used danger sign. Either they had a danger sign, and a danger sign in a child is if they are having chest indrawing, they are grunting, and they had to have image positivity, which is by lung ultrasound or chest x-ray. We conducted lung ultrasound on all these children. Or if they were hypoxic, made them severe. And hypoxia was defined by a saturation of less than 88%. And this was a case of pneumonia. To do this, we had nurses sitting in every large facility in our different regions in the hospitals to be able to capture these cases coming in through the emergency room. So to do that, we identified the hospitals where these children would present. In Peru, where I was running this program, we found 5 hospitals, and we ended up staffing them with nurses during the daytime hours and had an on-call nurse at night. We also did monthly visits to the home to find out if they did visit a facility and we missed them, so that we could go back and try and abstract any data that we could. We also, to make sure that we are being ethical about this, we had an education protocol to tell them that they needed to go to the hospital with pneumonia. So we had posters drawn and created with each of the symptoms. So chest indrawing, vomiting, slower and active, and we posted it in homes in each country. And we had a country-specific program poster. Over here on the left, this was our team of radiologists who interpreted all of our x-rays for us. And this was the training we conducted with them over in India. And it was during Diwali, so it was actually, we had a great time while we were over there too. What we found in the HAPPEN trial is the control is in orange and in purple is our intervention. We saw a significant reduction in our PM 2.5 levels. Unfortunately, we didn't see any changes in our outcomes. There was no difference in our birth weight of our children. There was no statistical difference in our severe incidence of pneumonia. There was an absolute difference, but no statistical difference. Stunting, there was no difference. And blood pressure in the older woman, there was no statistical difference. So why did this happen? Well, LPG stoves might not be the right intervention. We are finding out that in the United States and developed countries, using gas stoves might not be ideal for people. There's lack of ventilation in these homes. We didn't make people have chimneys for this study. Maybe that was something we should have done. And biomass might just not be the issue here as to why they have poor health. Is it socioeconomic? And our intervention period may not have been long enough. So this work is continuing on as we have this large cohort. There is a trial called HAPPEN 2.0. It is a 3-country follow-up in Guatemala, Rwanda, and India. They're in year 4 of 5 now, where they're following these cohorts of children, primarily focusing on neurocognitive outcomes in these children. And there is a respiratory-focused follow-up in Guatemala. Our team, though, was funded in October through NHLBI, which I don't think exists anymore, but we called it the longitudinal follow-up of a cohort of children in Puno, Peru. And we are looking at the LEAP study. So we are following these children that we enrolled in LEAP in our original HAPPEN trial, and we are looking at their lung function and neurologic development. So for lung function, we're doing oscillometry up until the age of 7, which then they can convert to spirometry. We are also measuring exposures, so we will be able to build a long-term exposure response curve and see how this impacts lung health. Okay. Well, so I've talked to you about each different piece here, and our trials so far have only targeted household air pollution. So we have all these different pieces. Should we be doing more? And the answer is yes. Should we be targeting more than one cause? Yes, because it won't solve the problem just to give vaccines. It won't solve the problem just to reduce household air pollution. The only current WHO recommendations for lung health are to increase physical activity, and we've already talked about where the barriers are there, and then inhalers for asthma and COPD, and that pretty much is salbutamol is what we get over in these countries. So we have just started a very large project called the Intervening for Lung Health Interlung Trial. This was funded through the Global Alliance of Chronic Disease, which the NIH is part of, along with multiple other countries, including the MRC, the Australian government, and multiple European nations. And the goal for this project is to adapt and test a multi-component intervention to protect lung health throughout the lifespan. And we're doing a special type of trial for this called a Type 1 Hybrid Effectiveness Implementation Randomized Trial. I'm going to get to a second what these hybrid trials are, which are the new wave of doing research in these areas. This program is to utilize a community health worker-driven strategy to prevent accelerated lung function decline. So, what are we going to do here? We're going to enroll participants in Bhaktapur, Nepal, age 9 years and older with a pre-bronchodilator level, pre-bronchodilator FEV1, FVC at the 10th percentile. So they have lung function impairment, and they have to have chronic cough and wheeze. We're doing this by conducting a large-scale census of the population of Bhaktapur. We are going to probably have to screen about 21,000 people in order to get this sample. From here, we are trying to enroll a sample of about 800 participants, and we're going to randomly assign them to our intervention or to our usual care practices. This study is also going to be interesting because we are not only enrolling the person with the impaired lung function, but we're going to enroll every household member. So theoretically, we are expecting to have about 2,500 people in each of our arms. So what is a hybrid effectiveness implementation study? So on average, a study to get from bench to bedside is about 17 years, which sounds insane. So we do the bench research, the basic science, then you do your clinical study, then you have to figure out how to implement it. Each of those are a defined step. The goal here is to combine the last two steps where you look at effectiveness and implementation together into a hybrid design. So in this study, we are not only looking at does this intervention work, but we're looking at how to implement it and is our implementation strategy effective. So here are our different interventions. We are going to implement masking and hand washing during peak viral season or when household members are sick. We're doing this by we have up here the Twistle app, but we're going to do mHealth to text people when there's a high viral level out and for them to be wearing masks. We're going to do education with families on when to mask in the household. Tobacco cessation, we are going to be doing a tobacco cessation campaign with our intervention households. Our intervention households are also going to get HEPA air purifiers and vacuums to remove the allergens. We will use on high pollution days, participants will be notified via mHealth to wear masks. We say N95s here. That is something we're looking at if that's practical. Vaccination. We are coming up with a plan to vaccinate participants against some of our major diseases. This has, I'm just going to go ahead and say, has already posed a big problem, as Gavi, which provides the world's vaccines to the low and middle income countries, has been largely unfunded. So this is one of the barriers we are working on right now. And then exercise and encouraging walking, and we're having groups of participants wear devices on their arms of some sort. This is a collaboration across institutions with Johns Hopkins, at MedStar, Georgetown. My partner here is Dr. Hannah Aram, who is faculty in Lombardi Cancer Institute, and Tribhuvan University in Bhaktapur, Nepal. Our outcomes are our differences in our intervention and control groups and our pre-bronchodilator FEV1 Z-scores. Z-scores are often used in research studies for lung function. Then secondarily, we're looking at our St. George's Respiratory Questionnaire and other lung function. And then implementation, we're concurrently looking at with our rates of adoption, acceptability, appropriateness, feasibility, fidelity, and potential scalability. Just for more fun, the Bhaktapur district of Nepal, it's fairly densely populated. This is myself there about, I guess, 14 years ago now, standing in Bhaktapur. Their ethnicity is Hindu and Buddhist. And one of the interesting things that we're having to think about is Ayurvedic medicine is popular. So participants just don't go to the hospital. If they're sick, they go see their Ayurvedic medical provider before they do anything else. So this is something we really have to consider when developing interventions. COPD is very prevalent, with an 18% prevalence in Bhaktapur. Just a little perspective, it is associated with 3.2 million deaths worldwide, and 90% of the COPD deaths occur in the low and middle income countries. Bhaktapur is a very highly polluted area with our fine particulate matter levels well above what we would consider acceptable here in DC. So, and this is on a daily basis. And there's a lot of burning going on for spiritual reasons on top of not only just the generalized environment. So we are in the first 4 months of this trial. As this is an implementation trial, we are trying to design this intervention to really meet the needs of our participants. We know that these different aspects of masking, vaccines, all prevent decline in lung function, but how is that actually practically involved in someone's life? I can't just walk in and tell somebody, hey, you got to wear a mask every day and expect them to do that. We know that does not work. Let's just be honest. So how do we do this? So our first step, and we're conducting these in September, are called human-centered design workshops, in which we involve very key stakeholders along with potential participants, and we have them co-design solutions together. The focus of this is really on how do people, more on practicality, and they say, and it's described as empathy, but how will it really actually work for people and meet their needs, and are they going to do it?